Good afternoon and welcome back. So in week 13, we'll continue to learn about mental illness, and in class 2, we'll talk about therapy. I did make a mistake in the first lecture this week, and I went back and corrected it in 2 ways. So it's corrected in the video, so you can watch from about 45 minutes to 53 minutes on the video, and the link I sent you will take you directly to that time point. And then I also corrected it in slide 32. So please take a look at that. I found another mistake, and when I was looking at the back end setup in Brightspace on your quizzes, I saw that I had not always checked show answers. So for some of your quizzes, you got all the feedbacks, and for some of them you didn't. And now I've gone and fixed that all, so you should be able to see it. So please take a look and review that, especially since I'll be doing a lot of grading and grade reviewing next week. And so the sooner I can get that in, the better. Another update. So you've learned about the Big 5 as a personality measure as the gold standard. And I was very interested to learn about an updated version that's the Big 6. And I talked to Nick Rulin about it, who's the professor in the psych department that specializes in that. And he's an advocate of the Big 6 as well. Now, this is not going to be on your test. Doesn't affect your assignment, but this is just for your information, because going forward in my own career with clients in teaching and research, I'll be using the sort of Big 6 from now. It's called the Hexaco Model. And what it does is that it disentangles disagreeableness and conscientiousness from kind of unethical behavior. So you could, here's an example of 2 pretty disagreeable people that, upset people. Vladimir Zelensky had really low approval ratings before the war. Like, he'll sort of say things that he thinks are true that upsets people. Very different kind of guy than Vladimir Putin, but they're both very dominant. So it disentangles dominance from, well, kind of self-serving, unethical stuff. So the Hexaco model adds a 6th dimension. It's the green one there, which is honesty, humility. And that is a trait that represents the tendency to be fair and genuine when dealing with others in the sense of cooperating. So if someone was really high on honesty, humility, they might avoid manipulating people for personal gain. So they wouldn't be, say, lying. They wouldn't feel much desire to break rules to get their way. They wouldn't be interested in crazy oligarch wealth and luxuries, and they wouldn't feel any special right or entitlement to elevated social status, the way somebody with, say, narcissistic personality disorder might. And then somebody with a really, really low score on that scale might, say, compliment others to get whatever they want, even if they don't believe it. They might be inclined to break rules for personal gain and be motivated by material gain and feel a strong sense of self-importance. So I'm telling you that so that you know about it, because it's, I think, an important update, and I will be using that going forward, so say in further classes. Okay, so today we'll talk about therapy. There's a few different schools of thought, say psychodynamic, humanistic, and there's cognitive-behavioral, dialectical behavioral, and acceptance and commitment therapy. So I'll run over those, and then we'll talk about how to evaluate whether therapy and interventions work. And then I'll end the class on a note of what I think has been the unifying theme, which is about adaptive behavior and resilience. So let's say that somebody has depression. They have a diagnostic label of depression. They've been diagnosed with depression. That means that in the estimation of an authority, they have met these criteria. But not all authorities speaking to the same person might agree. Maybe many of them would. We would hope that they would. But sometimes you get a second opinion, and someone might say, no, I don't think that really qualifies as depression. Maybe that's dysthymia or something else. Get the idea? It's not like a blood test for scurvy. This is a cluster of symptoms. The person is sad. The person has really low energy. The person has negative thoughts. The person might be thinking about death. Okay, it's a cluster of symptoms, but that we can't assume that that has one cause. And we often want to think that way. And there's one thing that you have to do to fix it. But what if there isn't one cause? What if there's like 100 causes and there's 100 little things to fix? And what if it doesn't take 3 sessions to do that? And one person, what if it takes, I don't know, 3 years? Lots of different people. Maybe there's a psychologist, maybe there's a psychiatrist, maybe there's a doctor, maybe there's elders in the community, maybe there's a priest or a rabbi or an imam, maybe there's friends, maybe there's journaling. I could keep going. There could be so many little things that change a course that has come to look like that, because you don't know what's causing it, right? So you don't know what's causing it, and it could be things that people don't even tell you about, right? So maybe they're stressed. We know that stress tends to precipitate depression. Maybe there's trauma that they haven't yet integrated. I think that'll suck the energy out of someone. Maybe someone's judging themselves using social narratives that don't and were never designed to support their success, and you need to challenge those in a therapeutic setting. Maybe they're not getting enough sleep. Maybe it's diet. Like some people react to foods in ways we don't expect. Some people feel kind of crappy after they eat dairy. Some people feel great when they eat dairy. There's so many little things that you might need to tweak, or that they would tweak. And maybe it is just a simple biochemical problem with their norepinephrine or their serotonin. And the magic T is an SSRI. Or maybe they're in a social environment that's undermining them, and you need to change the environment or pull the person out of that environment. So it could be so many things that lead someone there, and it's almost hubristic to assume that it could all be identified and fixed by a single professional in a few sessions that's all covered under someone's insurance. There are both pros and cons to diagnosing mental illness, to having that big book of the diagnostic rules of the mental illnesses. And one pro is that it gives us a common scientific lexicon. So when we say the word depression, especially in a sort of scientific psychological context, we all know what that means. That's useful. That means that we can do research into depression, talk about what might cause it and how you might treat it. So you can go to Google Scholar and type in depression and get a whole bunch of papers about depression that are useful. So it connects us to helpful information. And there's a lot of knowledge out there. So for instance, with schizophrenia, we know that it tends to become more severe over time. But we know that most episodes of depression seem to resolve on their own. I will add, this is not in your textbook, but I think it's something we should think about, is that there's an industry around helping people with their mental health. So the going rate for psychologists registered with APNS is, I think it's something like $225 an hour. And when there are drugs that treat conditions, there is an industry behind that. And I'm not knocking pharmaceutical industries. I think they're often very proud of, the things they come up with that genuinely help people. But there are also business interests there, right? It would be naive to pretend that those didn't exist. However, when we call somebody mentally ill or identify them as disordered or sick, that necessarily almost invites stigma, because then we're bad appling them. We're saying, well, there's a way that people should be. There's something that this person should be like that they're not. And there's going to be a lot of social construction, a lot of value judgments around what that ideal is, and deciding what is a deviation from the ideal and what's a big enough deviation to say, okay, this is a problem that we need to fix. Okay, so there's pros and cons, and please be aware of them. For some people, having a diagnosis or a label really, really helps them. And other people, that doesn't help them. There's a lot of individual variation. The major approaches to treatment are psychotherapy and biomedical therapy. So we have that psychological model, and then there's that medical model. Some people combine them. Now, if you're a psychologist, you can't really combine biomedical treatments that involve drugs because you can't prescribe the drug. However, maybe you're working in a circle of care with a family doctor or a psychiatrist who can do that. Sometimes people are helped by groups of professionals. But it's psychiatrists who have the domain of prescribing medications, prescribing drugs to treat mental illness, and family doctors can do that too. So psychotherapy refers to psychological techniques that are derived from psychological perspectives, like the psychodynamic perspective, which has the idea that a mental illness is caused by some unresolved conflict, probably from early childhood, that is ego-threatening, that we need to identify and resolve. Or maybe there's a humanistic perspective that thinks about, okay, what does this person need in order to grow to be their best self? And what kind of environment would support that? And so psychotherapy refers to a trained therapist using psychological techniques to assist someone to overcome difficulties or achieve personal growth. So what do they mean by trained therapist? There are terms that are licensed and terms that are not. A lot of people, if psychotherapy is using psychological techniques to help someone with their psychological problem, you can imagine that there's a lot of that going on, and it's not all done by a registered psychologist with PhD. So the term psychologist is registered. Now, you have an American textbook that talks about American requirements, and that's one more reason I want to change the book. I'd like it to be a Canadian book, but registration requirements differ by jurisdiction. So they're different in Canada, different in the States, different in Europe, different by province in Canada. And then they differ over time. So maybe they're going to change some requirement. So in Nova Scotia now, psychologist is a registered term, okay? And there's hoops to jump to. If you want to call yourself a psychologist, you have to have at least a master's degree. And then there's the Nova Scotia Board of Examiners in Psychology gives you an exam, and you have to have supervised practice, and et cetera, et cetera. Then you'll hear the term counseling therapist. This is also a registered term by a different body. There are different professional associations in psychology, and one of them is the CPA, Canadian Psychological Association. They have a code of ethics. They have members. But in Nova Scotia, the professional body that says, yes, you are a registered psychologist is the Nova Scotia Board of Examiners in Psychology. And then there's a different professional organization that registers counseling therapists. And I think they're associated with the CCPA, which is the Canadian Counseling and Psychotherapy Association. So this is more of a counseling thing, and this is more of a clinical thing. So counseling therapist is a registered term, but counselor is not, and therapist is not, right? You could have a Reiki therapist, and consultant is not. And this one's used heavily in IO psychology. IO psychologists tend to not seek registration. There's reasons for why people do or do not seek registration. And then coach is another one here. So if you want to do this kind of work, you can do this work, but there's different paths to get there. And there's pros and cons to each of those different paths. And you have to consider which one's a fit for you. I decided not to pursue registration, so I looked into it and I met the criteria, except there was one thing they were concerned about. I took ethics here and I loved it and got an A+, but I took it electively. I wasn't forced to take ethics. I chose to take ethics. And they're saying, no, for you to be registrable, your program had to require you to take ethics. And I'm like, I took ethics. And I just didn't want to deal with that level of hair splitting. And I'm kind of, I don't know, I'm sometimes a little bit skeptical of the medical model anyway. So I decided not to, and I'm happy with the counselor thing. And I love the CCPA. So my point there is that there's different ways of doing this. Lots of different people do it, including paraprofessionals. If you are a teacher, if you're a social worker, you'll probably do counseling at some point. And you've probably already done it with your friends. Okay. And then many practitioners will use an eclectic approach. So it's not like they're a psychodynamic psychotherapist and all they ever do is what Freud taught. I don't think you'd even find that anymore. So there's a lot of therapists that might use a little bit of this school of thought and a little bit of that. So you might see a lot of flexibility and flow. So let's go back to psychodynamic therapy. That's what Freud founded. And the goal is to help people understand their symptoms and explore and gain perspective on these unconscious thoughts and feelings that's driving their behavior they might not be aware of. The assumption behind this model is that there's, let's say, early traumas, there's conflicts that you're too uncomfortable about to think about explicitly, that you need the psychoanalyst or the psychotherapist to help you bring up. And then the psychoanalyst will look for the symbols there and figure out what's really going on, what that dream really meant. And it helps the patient understand how past relationships create themes, create issues where they're acting things out in present relationships that are really about the past relationship. So let's say that you had a really tough relationship with your dad, with your parents. Well, maybe that's the reason that you have trouble with authority now and rebel against your boss and your teachers. I'm speculating, get the idea. It's not totally irrational. We do learn a lot from our early experiences. They're formative. They could be affecting us now. Maybe talking about that and thinking about that would be helpful. I highlighted this because when you have a medical model, you'll see the person using services called a patient. That's a very medical model word. And I highlighted this here because it's client. Client is a much more kind of humanistic word. It's a bit more of an adult relationship. The idea that that this is somebody coming to you to seek your services kind of as a consultant. And they're going to think about it and they'll do what's best for them. It's a different kind of relationship. So the humanistic perspective puts an emphasis on people's potential for self-actualization, which is being the best they can be. Maslow told us what he thinks that looks like, and you might look at his list and say, yeah, that's what I'm aiming for. I'd be like, no, that's wrong for me. So Maslow's idea of what a self-actualized person is his opinion, and it's rooted in his experience of the Blackfoot tribe in Alberta in 1935, but no one ever ran this by them and said, hey, this is what we think you're doing. Okay, they might look at that and say, nope, you were totally off base. The goal of humanistic therapy is to promote personal growth. And if somebody has some tension, some conflict, some issue, we try to reduce that so that they can continue to grow. grow in self-awareness, grow in self-acceptance towards achieving their goals. So there's a focus on people taking appropriate personal responsibility for their difficulties. Often there's a social construct and a social context behind people's problems. And you have some agency for personal responsibility, but it's limited. I think the humanistic perspectives realize that because they have a bit more of an emphasis on social context. It's much more focused on the present and on the future, less interested in kind of talking about the past. And the role of the therapist is to actively listen. And Carl Rogers had a technique for active listening, and it involves things like, looking like you're listening, nodding, repeating back what the person says, but checking to see if you understood correctly. So really listening to the person in a way that engages them, right? It's not like they're free associating and talking and you're sitting behind the couch with your notepad being like, oh yes, this cigar is definitely a penis. That's not checking back to see if they agree. But this is a more engaging approach. And the therapist tries to model genuineness, authenticity, acceptance, empathy, and unconditional positive regard. I believe this is a test question. So how are psychodynamic and humanistic therapies similar, and how are they different? Could you give me anything? How are they similar? They totally different? They have nothing in common? Yes. They both try to give people a perspective and insight. Absolutely. They both aim at insight. And in psychodynamic therapy, we're gaining our insight from these things that happen to you when you're a child. But in humanistic therapy, the insights could come other ways. Like a big question for Carl Rogers is, what is this person's ideal self? What are they trying to be like? And what's the gap between them? It's also about like helping people. Like both of them are not trying to make a person feel worse. How are they different? Yes. Because the psychodynamic focus on the past, exactly. That's a really big one. So a past focus versus a where do you want to go in the future kind of a focus. What about the roles of the client and the therapist? Where do you see more of a kind of parent-child relationship? Which one would have a bigger kind of power difference? Yeah. So you have the expert that is going to see you, the patient, and will do the analysis and kind of say these are results and this is therapy we need. Whereas in humanistic therapy, it's more of a level relationship. It's a bit more of an adult-adult thing. So I think might just be called talk therapy. So you're talking to somebody and you're actively listening and giving your perspectives, but it doesn't have the same kind of, I'm the expert and here's what's wrong with you and what you need to do, kind of a model or way of thinking about things. Carl Rogers didn't even give a lot of these psychometric assessments to his clients. Where you fill in these rating scales, and if your score is below this, well, then you have symptoms of depression, and if your score is above that, then you're fine. Didn't even really like to bother with those. He was more interested in talking to people about, what's the kind of life that you want to be living, what's the kind of person you want to be, and where are you now? So he was interested in that gap, and how do we close that gap? They're pretty different ways of looking at things. Behavior therapies are based on that behaviorist tradition. Remember, we were talking about Pavlov's dogs. And the behaviorists didn't really care about your insight or your awareness or really what you were thinking or feeling at all. It was very external. What psychology focuses on is what we can observe and what you're doing. And can we change your behavior by administering a reward or a punishment? And so behavior therapy might involve classical conditioning techniques. So let's say that somebody drinks alcohol because it feels rewarding. Well, what if we gave them a drug that made them feel really sick when they drank alcohol? And now, when they try a taste of alcohol, they get violently sick. There actually is a treatment that does that. And it does help to some extent, but there are limitations because, well, there's issues. The person knows, right? They know they're on this drug, and they might know that when they're off the drug, they can go back to doing that. Another one we see is exposure therapy. So let's say that you're really scared of spiders. One thing we could do is try to pair spider presence with relaxation. So right now for you, spider is paired with anxiety. And the opposite of anxiety is relaxation. How could we pair spiders and relaxation? There's a whole process around that, but it starts with getting the person into a really relaxed state. And then we do something really non-threatening, like think of the letter S. And then maybe they have a little bit of anxiety and you help them get back down to normal, but they can be in a place where the word spider isn't scary. They can say it. Maybe next they can write it. And that'll involve some increased anxiety, and you bring that back down and you have that new level where they're okay with drawing a picture of a spider. Maybe even laugh at some cute cartoons. And you kind of keep going and going and going, and you can get to the place eventually where a person who once had a spider phobia or arachnophobia could have like a tarantula on their hand, and they're okay with that. Tend to use virtual reality for that because there'd be some probably professional liability issues with having a live tarantula in your office. So we use VR for that. And what I just described there is called systematic desensitization. Aversive conditioning can be, well, it can help a bit, like let's say pairing alcohol with sickness-inducing drugs, but there are a few limitations, and one of them is the ability to discriminate between the situation in therapy and then other situations, like, okay, when we're not on the drug anymore. And once you've established the effect, it's subject to extinction. And one missing piece is what is the new desirable behavior? So if somebody was drinking alcohol to get a reward, now you punish that, well, you haven't taught them what they could do instead. That's better. A very problematic application of aversive conditioning is called conversion therapy, and that's when psychologists have tried to change people's sexual orientation by pairing, let's say, images of who they might be attracted to with unpleasant stimuli to try to change that orientation. And I think all the professional associations are not in favor of that. We also use operant conditioning. So that was classical conditioning that we talked about. Now, operant conditioning is when you use reward or punishment to try to get someone to do something or stop doing something. So we're trying to modify their behavior by reinforcing a desired behavior, not reinforcing the undesired behavior. Like sometimes if you do something and there's just no response, you're not getting the attention you want, that's one way of discouraging it. Or another one could be by punishing it, by fining you, by taking away something that you like, or sending you to timeout. And here's an example of a behavior therapy. So every time James stays in his seat, he gets a star. But if he gets out of his seat, you take away the star. Let's say that what James really, really wants is to have lunch with a friend. Well, by the time he gets up to 5 stars, then he can have that. But critics, and sorry, this is called a token economy, and parents use them with children, and they're also used in care homes, and they're used in prisons. Critics might ask how durable are the behaviors, and will people become so dependent on the extrinsic rewards that the desired behavior will stop when this stops? So if you take this away, is James going back to running around the room? Because it was never really something he wanted. It was always about some extrinsic reward. You want people to be self-managed and independent. At the end of the day, they need to connect to their own inherent drives and motivations. So if you can make James really want to stay in his seat because that's the best place to be, then he will. You know what? Maybe it never really was. People who have depression, say, or anxiety or other conditions have cognitions. They have thoughts that represent those conditions. So let's say a depressed person might have very sad thoughts, very hopeless thoughts. And an anxious person might have thoughts that say, this isn't going to work, something terrible is going to happen. So mental disorders always have a cognitive level. When you have a feeling, there's a sensation in your body, there's an observable behavior, and there's a thought in your head. And cognitive therapy is about addressing the thoughts, and to teach people new, more adaptive ways of thinking or of framing things. And Aaron Beck is the father of this technique, and he would use gentle questioning to try to reveal irrational thinking and then persuade or lead people to change their perceptions so that they can recognize, say, unhelpful self-talk, recognize faulty assumptions. So let's say that you think that nobody likes you. Really sad about that. Nobody likes you. Well, how do you know that nobody likes you? Can you get in their heads? All of their heads? If you could, what would you find? Would many of them actually be thinking about other things? And really, what's in their head, is that any of your business? Like, aren't people free to their own thoughts and feelings? Like, maybe there's some people you don't like, and you want that freedom, and that's okay. So why shouldn't they have it? Why do you need people to like you? Let's sort of test the belief. So let's say you think that everyone should like you. What would your life look like if you had to make everyone like you all the time? You have to people please everybody all day long. They'd all want you to do different things. So if you start getting the person to think through this, it starts to become obvious that this is an impossible desire, and that if you actually tried to play it out, if you tried to step into that Kincaid painting, it actually doesn't work. So you might suggest to a person, well, it's okay if people don't like you. Disagreeable people have their place in the world. Right? They help groups make better decisions, and they make good cognitive therapists. So if somebody says something like, well, I can't do it because I might fail, and I probably will fail. Let's say they said, I tried something and I failed. So you might say, you failed? That's great. Good job. You learned something. Like, what did you learn about what you like, what you want, about who you are from that experience? What could you try that's new now that you know that? Okay, so cognitive therapy is about challenging the way people think and helping them think more adaptively. And it's even more powerful when it's combined with behavioral therapy. That's called cognitive-behavioural therapy, and it's an integrative therapy that combines changing people's thoughts with changing people's behavior. And it helps people learn to make more realistic appraisals and actually act more adaptively. If somebody is depressed and you somehow manage to drag them to take a walk and go for a walk, that they will feel better, say from the endorphins, getting out of the house. That's a behavioral therapy, but you could pair that with also addressing the thought. So it's more powerful. Some clients are really high risk, and some clients are much more difficult to treat. So there's a type of CBT that's called DBT, dialectical behavior therapy, and it's used, it focuses on high risk clients. So maybe people with suicidal behavior, with borderline personality disorder, people who might have extreme mood swings, could do things that are pretty impulsive. And you need to have a different relationship with the provider, and the provider needs to have different level of professional support in those cases. So if somebody's really high risk, you can't exactly be like, well, great session, see you in 6 weeks. You can't do that. And so in DBT programs, the clients would be able to, say, text message their therapist, like as things come up. You don't normally do that with a psychologist, but you need to have a higher level of engagement and a much higher level of support and availability. And in order for that to work, the provider also has to have a lot of support. So there's a consultation group for the practitioners to figure things out. And DBT focus on teaching good skills to cope with unhealthy behaviors. So there's a focus on acceptance, on change in a more adaptive direction. They teach distress tolerance, emotion regulation, mindfulness, and it involves more than one technique, right? So there's individual one-on-one therapy, right? There's group skills training, and then there's support for crises between sessions. Acceptance and commitment therapy is more appropriate for people who are more functional, right? So compared to DBT, you don't say ACT, you say ACT. ACT is for clients who are pretty functional. It would be less appropriate for folks whose negative thoughts and feelings are severely dysfunctional. But for everyone else, ACT invites people to open up to unpleasant feelings and to learn to not to overreact to them, not to avoid situations where they're invoked. So it's about accepting your uncomfortable negative thoughts and feelings as necessary and always present companions on your journey, which you're in charge of, but treating them with a kind of attitude of respectful custodianship and recognizing that a healthy emotional life includes negative emotions, and used adaptively, those become a resource and a source of strength. So ACT tries to develop something called psychological flexibility, and that refers to the ability to stay in contact with the present moment, right? Be here now, regardless of unpleasant thoughts, feelings, and bodily sensations. They're here with you, while intentionally choosing what you're going to do, choosing your behavior based on the situation and your values. It's about staying in charge, knowing where you want to go, and not getting entangled, in the narrative of dysfunctional thoughts and feelings. Being sort of mindfully aware that they're there, right? Like clouds passing in the sky or traffic on the road, and kind of making the room for that. We often think of people as individuals, which they are. However, we come in social groups, and a really important one is the family. Right? Most people you engage with are also coming with a family context. There's their mom and their dad and their uncle with an addiction and their kids and their stepkids. And family therapy tends to be more focused on children, like when a child is acting out. But when a child is acting out, it's often about more than the child and more than, let's say, their classroom setting, right? Maybe there's a dysfunctional family dynamic behind that. Sometimes when kids are being aggressive at school, They're actually acting out the way they see their parents deal with conflicts. And so the family therapist helps family members understand how their ways of relating to one another could be dysfunctional. And it treats the family as a system, and rather than judging it, it focuses on changing relationships and interactions in a more adaptive direction. Then there are group therapies. And we see group therapy when the client problems involve sort of social interactions with others. I feel like it could also be useful when people are dealing with something individually and can talk to other people who are going through the same thing. So I read that because it's from the textbook, but I feel like it could be useful for other conditions as well. Group therapy is much more cost effective, right? So you have, let's say, one psychologist there and then 5 or 10 people. So they're paying less per session. And it's happening in a social setting where people can explore social behaviors and develop their social skills. And it helps. A lot of people think that they're the only person in the world that's dealing with a certain problem, but now they're in a group of people who all have a similar issue. And it makes them kind of feel less alone, and they can even help someone else going through something similar. And then that gives a sense of value to your experience. And people in a group setting might try something new and then come back to the group and get to feedback on how that's going. With group therapy, we need to be aware of social dynamics, and we need to be aware of iatrogenic effects. So what does iatrogenic mean? There's an assumption that anytime we intervene or give a workshop or a session, it helped the person. And sometimes it doesn't. And if it doesn't help, then you just wasted their time. And sometimes it makes things worse. And we need to be aware of that. And that can be particularly the case with eating disorders. So sometimes if you get a group of people with eating disorders together, they might end up kind of encouraging each other towards, let's say, further weight loss, or they might compete with each other, or they might share tips and tricks. There was also reminded of a case. There was a psychologist at Dalhousie, and he got a group of people with depression together, and they're all quite depressed. And his idea was that it would be like a pet therapy thing. They'd bring a dog in. And because, dogs cheer people up, they're so happy. They brought the dog in the room, and it's wagging its tail, it's happy, and then it tries to go around to people. The people all are really sad, and they stay sad. The dog just like lay down in the middle of the floor and gave up. So maybe the sort of contagious sadness there wasn't the helpful thing to do. There are small support groups that meet regularly, and they can be organized around specific problems like addiction or bereavement. And these are interesting because they often occur without like a psychologist present. So when I say group therapy, it means that there's a psychologist there, and these are the 5 or 10 clients. But if you go out there, you can find a group of people who've lost a child, or people who are struggling with alcohol use disorder, and they're helping each other. And what I find really interesting is that there's one that's called Alcoholics Anonymous, and it was not designed by psychologists who are reading about psychological principles and publishing things in journals at all. It was very grassroots. So it's people who struggle with alcohol use disorder, of understanding it and helping each other. And what's interesting about it is that it is just as effective as the scientific kind of treatments. And so I respect that the people who are out there on the front lines dealing with the condition might know a lot about how to solve the problem, especially when they come together. What I will say about the 12-step programs is that I think they're faith-based, so they probably might not be the cup of tea for somebody who isn't religious, but they do seem to have pretty good effects. I made a joke about this and impulsively in my email to you yesterday. What is retail therapy? Do any of you do it? It's actually pretty common for people who are feeling anxious or sad to go out and shop. There is research that supports that this happens. And so it's a lay term, it's a bit ironic, but it is a thing. And it can get people into a situation where they're spending more money kind of binge shopping than they should be. If you are not feeling very good about yourself and you go buy something, let's say there's a dress or a shirt and you try it on and you look in the mirror and you're like, wow, I look great. I wanna look like that. Getting that and wearing it can make you feel better. And I hope that all of you have some, let's say, outfits in your closet where you put on that shirt and you're like, yes, you feel good and it expresses yourself. But maybe 5 of those outfits will do the trick. You don't need like 50 of them. And if you aren't feeling good about yourself, it's not coming from the inside, and you buy something, like maybe, especially it's like a status bag, and then you start carrying it around, you might feel good at first, but since it's not really coming from you, and it's coming from a material thing, that's gonna wear thin over time. And then you're gonna have to go buy another pair of shoes and another bag. So people can end up spending a lot more money than they should be, and financial stressors are real stressors. Okay, on to biomedical therapy. So biomedical therapy refers to using sort of medications or other procedures that act directly on the person's physiology. It's not about talking to them about their thoughts or their feelings. And the most widely used biomedical treatments are drug therapies. And one thing that's nice about drug therapies is you can do a lot of really rigorous research on them to see if they work. You can compare an antidepressant to placebo. You can compare a new antidepressant to an old antidepressant. You can compare an antidepressant to exercise. You can study the chemical molecular nature of the thing and how it works at a really low level. And the study of the effects of drugs on mind and behavior is called psychopharmacology. So the most common drug treatments are antipsychotics, anti-anxiety drugs, antidepressant drugs, and mood stabilizing medications. Antipsychotic drugs work by helping a person focus their attention better, because people who have psychotic disorders have their attention really drawn and sometimes fixated on irrelevant stimuli. So I'm like, oh, there's red on this package that was left for me here, and that is connected to Robert Somerby Murray's red bow tie. This is an irrelevant stimulus, and an antipsychotic drug would make me pay less attention to that and more attention to what other people are focused on. Anti-anxiety drugs are those sort of downers. They calm the body down. And there's a few classes of them, benzodiazepines, this, that, and the other thing, but they all do that because they help bring you down. So when you're anxious, you have that sort of sympathetic response. You're tense, your heart's going, and they help ease that. Then antidepressant drugs can energize people, kind of lift them up out of a funk. And then there's some drugs like lithium, which helps people who have really big ups and downs. It helps level those out. And so those can be great tools in the toolbox, but they all have their pros and their cons. So let's say if you use an anti-anxiety thing like clonazepam every time before you do something stressful, well, then you could ask, are you going to become dependent on that? Are you going to need higher and higher doses? Could you get addicted? Will you be learning the skills to go out and do that scary thing on your own? And the first time you do it, it's going to be really scary. You kind of have to go through that. There are risks to providing drug therapy without the appropriate psychological or social support. We've talked about how dangerous it can be to use an antidepressant to lift a depressed person with suicidal thoughts out of that physiologically depressed, I don't have the energy to do anything state, to one where they have more energy and their thoughts haven't changed. And that's when they might go and carry out a plan that otherwise they wouldn't have gone through with. So when prescribing an antidepressant to somebody with depression, it's really important that we're aware of that there's support, there's psychological support, and that they're observed, that there's somebody that cares about them, that knows they're on this, and that they could have this effect. Another issue we've seen with antipsychotics is that they helped people so much that they didn't have these behaviors that beforehand were having them be institutionalized and maybe in a straitjacket, because the healthcare providers there didn't know how to deal with it. So now you've got the person out of the straitjacket, and in fact, well, it's really expensive to run these psychiatric hospitals. Why not send them all home? What happens then? We've seen a huge amount of homelessness after that happened. And that's because people were not being provided, the people who are transitioning from inpatient care, where there was a lot of support, right? They're in a sort of controlled environment and a sheltered environment. So now being in an outpatient program was like, here's your prescription, take this. Yeah, come back to the outpatient clinic in a month, bye. And then let's say they don't have the life skills to manage on their own. So you say, okay, here you're on social support, you get $1,000 a month. Well, do they really have the skills to run a life on their own and pay the bills and get the groceries and remember to do this and remember to do that? And what if they need support with that? And what if they don't have it? Then what's going to happen? And that's how we ended up having a lot more homeless people. There are neurostimulation therapies, and actually I meant to have this slide first. So I'm going to jump to this one. Psychosurgery is dramatic, and that's when they were doing things like lobotomies. Like, there's a part of your brain that's a problem, let's take it out. Let's sever the connection. Obviously, that can have very serious adverse effects. And once you've done that, you can't really fix it. So we have seen psychosurgery for people with who are having real issues, like, let's say, terrible seizures that taking out half a brain. So this does sometimes happen, but it's kind of not your first choice. Lobotomy was a thing at one point. They thought that if people were overly emotional, why don't we just cut the part that connects your frontal lobes to your emotional limbic system? Oh, that'll calm you down. Caused a lot of issues for people. Like, some people really did not recover from that. So today we use less invasive techniques, and like neurostimulation, for example. Electroconvulsive therapy sounds really dramatic and brutal. You've probably seen it in that movie, One Flew Over the Cuckoo's Nest. It's much gentler now. It does seem to work, though. And I can't remember which lobe of the brain is, but one of your frontal lobes is a bit more sort of have a positive mood center, and the other one's a bit of a negative mood center. And if you knock out, I can't remember which it is, right? If you knock out the positive one and leave the negative one intact, then people are incredibly sad after that procedure. But if you knock out the negative one, then they're euphoric after the procedure. Transcranial current stimulation applies a weak current to the scalp, and it's sort of a bit questionable. Like maybe that's a placebo thing, maybe the currents aren't strong enough. Transcranial magnetic stimulation involves sending a magnetic field through the skull to the surface of the cortex to alter brain activity. And deep brain stimulation involves the psychiatrist using electrodes implanted in the sort of sadness center of your brain to calm those areas. And I hear you thinking, well, isn't that activating it? And no, it's because these things work by scrambling. And it inhibits them. ECT is like rebooting someone's computer. They don't remember the procedure, they wake up, have a reset, might feel better. So when you apply, so your brain has an electrochemical language and system, and when you go and apply some kind of electricity to that, it's gonna scramble it up. And maybe that's a chance to reset, maybe that's a way to inhibit certain areas. Probably the best, or one of the most important kinds of biomedical therapies, and one we probably don't talk about enough, is therapeutic lifestyle change. And that is about eating, sleeping, exercising, allowing yourself to take breaks in order to keep your body in a biologically healthy state. When you're sick, like think about when you had the flu last time. Maybe you had COVID. Right? How did you feel? Right? What were you thinking? Did you just want to crawl into bed? Lack of sleep is a major predictor of depression. So we can help ourselves out or help people out by supporting health behaviors that keep your body in its best shape. Now, we all know that you're supposed to do 30 minutes of aerobic activity 3 times a week, and you're supposed to sleep for about 8 hours, and you're supposed to eat your vegetables. Most people, and by most, I mean the vast majority, do not do that. It's probably something like 3%. They're doing those things and like not smoking. And that's because we're really busy. So if somebody is not well because they're, for whatever reason it might be, not taking the best care of themselves, let's say they're really underslept, or they're eating some food that makes them feel crappy, talking to them about their mother isn't going to solve the problem ever. So some therapists start here, right? At an intake, they want to know, how are you sleeping? And are you able to get exercise? Just sort that out first before going into these more complex philosophical places. So let's say that somebody has a behavior that they want to change, or something they want to do differently. We're assuming that everyone is kind of green light and saying, yes, I want to change this. But in reality, so let's say we're thinking about something like stopping smoking. Sometimes people don't want to change. And sometimes people get sent to a psychologist because someone else wants them to change. And this happens in the healthcare context when somebody is like non-compliant with their treatment. You go talk to a psychologist about that. And if a person is red light, then it actually doesn't help to push them and scold them and try to force them. And what the therapist does is to try to keep the conversation and the relationship going, right? Get them to come back again instead of be like, no, I'm done with this. And then you might be able to work the person to what we call yellow light where they're ambivalent about changing. They'll say, yeah, I like smoking because I like the taste of it, and I can do that with my friends, whatever it is. And then where they're also more aware of the real disadvantages. They say, well, I want to go for a run, but I can't because I'm coughing. It'd be nice if I could go for a run. And when they're in that yellow light state, you can help them find personally meaningful reasons for change, right? Like that align with their values. And then once they're green light, that's when you can get into the hardcore or the real behavioral strategies, like setting SMART goals. It doesn't make sense to try to make somebody set a SMART goal if they're not really into it. So moving on to evaluation, how do you know if a treatment works? Let's say that you go to therapy. How do you know if that was effective? You can ask the person, did that help? And they'll be like, yeah, I guess. But there's no control group that stayed home. There's no control version of you. And the therapist is always going to think that they were helpful. So it's kind of biased off the start. But we can do studies. We can have a group of people who are depressed and randomly assign half of them to get therapy and half of them to a wait list. And so if we combine all those studies together, then what do we get? And these are two distributions. And so this is your untreated group, and then this is their average on their outcome. Did they do badly or did they do well? So higher is better. And then there's a distribution here of the people who got assigned to treatment, and their average is there. And so you can see that there's an increase. So people do tend to do a bit better if they get therapy. Many problems resolve on their own. We talked about regression to the mean. So when people go see a therapist, they're at the bottom, like everything is awful. Like all 100 things in their lives are going wrong at once. And some of those things are going to sort themselves out on their own. And that's why people tend to get better anyway. But you could help them get better faster. Now, one problem with this kind of study, which is called a meta-analysis, it's called the final draw problem. So if you're doing research on scientific research on, let's say, whether therapy works, and your study suggests that it doesn't, well, what scientific journal is going to be interested in publishing that? Because there's a lot of people that want to get published. There's 500 submissions. We can only publish 5 articles. Let's publish the really exciting ones that show really big effects. And so those kind of more mundane reality ones about how things don't work and they don't get published. People might think, okay, I'll tweak something and then I'll get a significant effect. And so the result is that what gets published is the significant results, and that's a biased sample. That is an issue in scientific studies. So keep that in mind when I'm telling you this story. What psychotherapies work best? Well, it depends is often a good answer to a question, and some forms of psychotherapy work best for particular problems. So behavioral therapy works well for bedwetting, and client-centered therapy, not depression, tends to work for mild to moderate depression. But overall, one thing that's important is going in with a really specific problem. So you could go to see a therapist and be, I hate my life. How are you gonna fix that? Or you could go in and say, I am washing my hands 100 times a day, and we manage this. When you have a specific problem, focus on solving, you're more likely to get it back. Go in with that kind of vague general problem. We look at all the different kinds of therapy and say, well, what works? This is kind of what comes out of it. Effective therapies happen in an empathic, caring relationship, not with a therapist who is treatment. And that person provides new perspectives on yourself and on the world. Think about things in different ways. And you feel a sense of hope. Those are the 3 things that you need to have. Research has not found any effect on outcomes cognitive therapist experience, training, supervision, or licensing on psychotherapy. So you'd sort of think that, only a qualified professional can do this. The research doesn't really support that. And as you go through your life, there's many people that will help you that are not your registered psychologist or counselor. It's some friend, it's someone you met on a bench, it's somebody you walked in the park with, right? And you could bring together all of those things. And counseling or psychotherapy is regularly provided by therapists, by social workers, by nurses, by teachers. They'll have those sorts of conversations with you. So that's to say, licensed psychologists with PhDs do not own the market to find helping people. It's important to remember that sometimes treatments hurt. Remember, I kind of ran out of time on another lecture. I'm going to get to talk about it. But there's something in the 90s. I remember when coming into my school, it's called drug abuse resistance education. And I remember a uniformed police officer coming into my school, and we all sat there talking about how drugs are bad and gangs are bad. You should definitely not do this. So it was an education program that sought to prevent use of controlled drugs, membership in gangs, and violent behavior. It was founded in 1983 as a joint initiative between LAPD and the Los Angeles Unified School District as a sort of strategy related to the American War on Drugs. And a lot of money went into this. When they did the research, it looked like it actually made things worse. Like at best, it did nothing. Why might that be? Anyone want to speculate? So why this amazing program is going to teach you that drugs are bad, and a uniformed police officer coming into the school will tell you that. And when they're working.
I don't know if it's the same in the city, but I grew up in the valley, and when they showed us as kids, like they had like a big poster of like drugs with like little examples of the plastic. And it like introduced us to a whole new world of drugs we were interested in.
Yeah, you didn't know about this before.
I had no idea.
Yeah,
I had no idea.
That's
like,
one reason. Yeah. Sometimes they tell students don't cheat, but they don't tell them all the ways they could cheat, so they don't want to give them any idea. The other reason is like, if they're going into communities to try to reduce gang violence and drug use, they're probably going into racialized, criminalized communities. As like what, a white cop in uniform? And I think that kids are going to identify with that and say, yeah, I want to be just like that guy. Right? Those police officers have very different relationships with those communities.
We also didn't kind of like split certain drugs up from very dark drugs. Like they had like marijuana and heroin on the same board. And so a lot of people that I knew when they did the routines kind of equated all drugs to the seriousness of them.
Okay, so they're messing people up. Yeah, not even giving good quality education. There's often more of a political message behind it, yes? Yeah! Yeah, you're like, that's a really good point. Don't do this, it'll ruin your life. And you're like, well, that's really, that's a good point. And all this is to say that it is really important not to assume that something works and is great, especially if you're going to put a lot of people through it. So there's ways that scientifically we can investigate that and see if it helps or hurts or does nothing. And if it does nothing, it wastes someone's time. So evidence-based clinical decision-making will want to consult with that available research evidence. I will add that a lot of research is done on surveys. The person judges, analyze and says, yes, this worked or didn't, and there's less emphasis on qualitative research that goes back to, hey, how did you experience that? How was that for you? And that level of listening is actually quite important. Okay, and then the therapist is going to have their own clinical judgment, expertise, opinion, and then fit is important. So not all therapists who are out there are going to be the right fit. Okay, I'm disagreeable, so I like the cognitive therapist. I didn't get anywhere with people who got therapy. You might want someone very empathetic. It's those three things need to work together. Now, your book talks about resilience and defines resilience as having a personal strength to help you cope with stress and recover from adversity and trauma. I do not agree. That is adaptability. Okay, so adaptability, as you know, the readiness to use your resources to respond in effective ways to get what you want. And that is what produces a resilient outcome. A resilient success after the fact. You say, oh yes, this was a resilient team. And they were resilient because they had the skills and through the resources that they can use skillfully. If you look at these risk factors for mental illness and protective factors against mental illnesses, what I'm seeing there's resources and responses. So for risk factors, chronic pain, low socioeconomic status, having a medical illness, stressful life events, those all represent low resources, like poverty, which is low resources, or there's something that sucks your resources away. Like you have a trauma experience, they'll just suck them all up. Okay? And then the other ones are responses. They're about skills or work skills. Substance use. Substance abuse is not the ideally skilled way to deal with, let's say, to regulate emotion. Now let's look at the protective factors. See a lot of them that are about more resources, right? They're about having social support from family and friends. They're about economic independence. I mean, wealth. You have more financial resources. Aerobic exercise increases your physical resources, your energy resources. And having feelings of mastery and control will do that too. And then look at a couple other responses. There are adaptive responses like problem solving skills, resilient coping with stress, so coping skills. Kind of the same thing. And then having social and work skills. So, I hope you can get yourself caught in a positive spiral where you buffer your resources and learn better skills to get the results you want. And that in turn will increase your resources even better. On the way out of a negative spiral is to find some adaptive way to respond. So, for Sunday at 5 p.m., you have your week 13 quiz, and you have assignment 3 on self-personality. The last date or time for the extension request is April 15th at 5 p.m. I'll post the final grades on April 18th. How are you guys doing? Yeah? It's been an honor and a pleasure being your instructor, and could you join me in giving yourselves a round of applause? You've done really, really well. Okay, so if you're going on in psychology, your advisor is McIntosh. There is a psychology graduate society that you can reach out to, and there's a conference on Friday. Maybe I'll see some of you there. Thank you.